Joining us on the line is Dr. Marty Makary. He's a health policy advisor to Presidents Trump and Obama, editor-in-chief of MedPage Today Surgeon, and professor of public health policy at Johns Hopkins. Dr. Makary, thanks so much for joining the show again. Really appreciate it.
Good to be with you, Ben.
So as you watch the trajectory of the testing in the United States, a lot more tests being given, a lot more positive tests coming up, obviously, and a lot of deaths. We've now surpassed 800 deaths in the United States from coronavirus. Do you have any sort of beat at all? It's very difficult to get any sort of real estimate as to where this thing is going, whether we look like Italy in a week or so, particularly in New York City. What's your take on where this thing goes in the near term?
Well, first of all, thanks for having me on, Ben, and keep up the great work with your show. This virus is following the playbook. This is playing out exactly as we had predicted in all the models and projections. And we are probably still about 3 or 4 weeks away from its peak. And the big concern right now is that during that peak, we are in a position to ration care because we just don't have enough ventilators, and our response has been a little slow. Now, when you cite the number of deaths, and you did it just as our Johns Hopkins map, which has been very popular, has done, remember, you could probably multiply the number of deaths by 2 or 3. And we can probably multiply the number of cases by 10 or 20 because, as you know, there's not been a lot of testing out there. And hospitals are telling us they have a lot of what they call influenza-like illnesses that are in the critical care unit, but they've just not been tested. And to be honest with you, that's not been the priority to test them. They're busy taking care of people, and the test often doesn't change the management unless you start talking about some of these newer medications.
So, Dr. Makary, I suggested this morning that there were basically two things that can be true at once. One is that the death rates that we're seeing are actually really inflated. The number of people who actually have the coronavirus, don't know it, haven't been tested for it, is significantly higher, as you just mentioned, than the number of people who have been tested for it and found positive. And also that even if the deaths are more numerous than we already know, that the numerator over the denominator is going to be a lot lower number than even 1.3%, or certainly the 8 or 9% we're seeing in Italy. At the same time, because this thing is so transmissible, the sheer overwhelming absolute number of people who end up in an ICU could overwhelm the system anyway. So the good news is that if you have coronavirus, you may be less likely to die than 1.3%. The bad news is that a lot more of us are going to get coronavirus, and so a lot more people are going to die.
That's exactly right. And, I personally think that case fatality rate, that is the percent of people who die who actually have the infection, is below 1%, not far below. It's probably, in my personal opinion, around 0.8%. If we look at the Diamond Princess cruise ship, it was kind of a laboratory. 705 people got it, 7 died from it, and those were confirmed cases and confirmed deaths. We know that it's hard for this virus to hurt a young, healthy person, that is somebody in their 20s and 30s or younger. We know really no child has died from this except for a 14-year-old and a 16-year-old. So when you talk about kids under 12, they can be transmitters, but they're relatively resilient. And I think you're exactly right. Look, we learned a lot from a memo internally at New York Presbyterian Hospital, where the chief of surgery, and this memo has been on the internet, I tweeted it earlier this week, that he said we've got 300 COVID-19 cases at New York Presbyterian. By the way, that's about a third of the capacity. A big hospital like that, like mine, has about 1,000 beds. But only 100 have tested positive because they just haven't tested the other 200. They haven't had tests available. So that tells us a lot. Now, in that memo, he said we will probably need about 1,000 ICU beds at Columbia Presbyterian Hospital within the next 20 to 33 days. That tells you the mass need to flatten the curve, reduce community transmission, keep people hunkered down, and reduce that peak when it does happen, because that will be a mass rush and a mass influx that could, and right now will, result in a rationing of ventilators, something we don't want to see and something we're trying to prepare for by making one ventilator work for 3 or 4 people.
Well, speaking about the ventilator situation, for folks who don't know what a ventilator is, first of all, why don't you explain what a ventilator is? Because we sort of hear it and we think it's an air conditioner or something. So what exactly is a ventilator? How vital are they? And how many of them are we actually going to need if the estimates are correct versus how many are in circulation right now?
So when the lungs get inflamed, when there's a lot of fluid in the lungs, when your body responds to the infection in the lungs by sending inflammatory mediators, including white blood cells. The lung tissue gets inflamed and it can't exchange oxygen well. So you have trouble taking a deep breath in. You have trouble getting enough oxygen. The ventilator blows air in and forces it in, and it's what we call mechanical respiratory support. And so particularly people who have lung disease or a later stage in life need that. Now, we know that about one person for every 2 people we put on the ventilator will come off. The ventilator is a crutch, and it helps them breathe for the days or few weeks they need to get the strength, to get that infection cleared, to get the inflammation down. And so we can save about half of people that we can give a ventilator to in those late stages of this illness. So what we need to do is figure out how are we going to get these ventilators to the people who need it. Right now, our country has about 130,000 ventilators, broad estimate. By the way, isn't it kind of embarrassing that nobody knows how many ventilators we have? I mean, you literally see our top health officials, and it's not their fault, right? These ventilators might be in the basement of a hospital. They're 10 years old. No one knows if they work, and so no one's done the tally. But we know that our country has about 100,000 ICU beds. If we take the low end of the estimate of this infection, say 20% of our 350 million Americans get this, and 15% of them need a ventilator or need a hospitalization, and a quarter of them need a ventilator, you're talking hundreds of thousands of ventilators. In one of the models that I have, 700,000 Americans could need a ventilator. We've only got 100 to 130,000. So this is going to be tough times.
So for a second, let's talk about sort of broader questions that I think people are asking right now. We sort of assume a level of competence or understanding of the healthcare system many people don't have. So when we say that somebody's been transferred to the ICU, what percentage of people who are transferred to the ICU are going to die in the ICU, and what percentage of people are going to come out? Because I think there's a widespread perception that if you end up in the ICU, you're dead.
Yeah, ICU does not have a good reputation out there in the world. But an ICU is really an incredible tour de force of American healthcare and our technology and best practices. The reality is the virus runs its course, and there's little we can do except support your body, keep you nourished and keep you strong, provide you the fluids you need to let you recover on your own. And we know about 1 in 2 people who get the ventilator survive it. The other 1 out of 2 people never comes off the ventilator, unfortunately. So right now we need to think about what percent of people will need a ventilator, and how can we predict using models, right, the right number. And it's we think about a quarter of the hospitalized patients need it. Now you'll hear statistics that less than 1% of the deaths are in people under age 50. And the reason is they're the ones who are getting the ventilators. They're the ones who are getting the support. And in countries where they've rationed, it goes to the younger people. I don't like those questions. I hope we're never posed with that. But right now we're projected to be in that dilemma.
So, Dr. McCary, when somebody's in critical condition, does that mean that they're necessarily in the ICU? Because how do these conditions work? You've seen people listed as serious or critical. What do all of those sort of categorizations mean?
So both critical, guarded, and unstable refer to being in an ICU with nonstop monitoring and being often on a ventilator. And that means that there's a decent chance, say 50% or more, that we're concerned you might not survive the ICU stay. The other terms are usually what we call transition terms, but those are the ones that refer to an ICU level care. And typically we just refer to that as critical care.
We're speaking to Dr. Marty McCary, health policy advisor to Presidents Trump and Obama and editor-in-chief of MedPage today. So, Dr. McCary, some of the things that people have been talking about are also treatments that are being made available. There's been talk about, for example, using blood plasma of people who may have recovered from coronavirus. The FDA is now approving that in sort of crisis cases. They've talked about the use of clinical trials in order to see if this stuff is effective. The problem with the clinical trial, presumably, is that you have to have a control group. And who the hell wants to volunteer for the control group in a clinical trial when you've got coronavirus? So some of the solutions that have been talked about are blood plasma. Obviously, the president has really talked up hydroxychloroquine. what do you make of some of the supposed treatments that are being made available? What are the data on these things?
Well, there's some early data that sounds promising. And to be honest with you, some of the most exciting things are not even the things that have been out there in the media. I mean, I know of a scientist who has a medication that reduces that body's inflammatory response that damages the lung. And that can help get people through this virus. And I believe it will rescue people. But he's not getting a call back from the FDA. And what is so frustrating is to see these old guard physicians, the medical establishment, which, by the way, I love them and they've got great qualities, and my dad is one of them. But they have this mentality that unless you have a randomized controlled trial, it's basically snake oil. And that is the thinking. And look, we love randomized controlled trials, but they take time. They're very involved. And we can learn from patients. We can learn from individuals. We can learn from a series of individuals. We can learn from before and after observations. We can learn from scientific inferences. I mean, do we need a randomized controlled trial to prove that a parachute works if somebody jumps out of a plane? No, we use scientific deductive reasoning.
So Dr. McCary, I want to ask you also about the sort of timeline here. So you've mentioned it may be 3 or 4 weeks until we hit the peak of this thing. That does raise questions about whether it's going to get wiped out by they're basically, from what I've heard, several sort of paths to this thing mitigating to the point where people can go back to life. One is the long-term vaccination. Obviously, people are going to have to go back to work before a year or 18 months, or the entire world economy will just shudder and die. There's also the possibility that the summer helps mitigate some of this. There is the possibility that over time, because we've so failed to contain this thing, that some sort of herd immunity is built up. And then there's the sort of, okay, well, we've done the best we can. We've gotten some resources in place, and now we have to start transitioning people back to work. Presumably, that's what the Trump administration, and President Trump particularly, is talking about when he says he'd like to get people back to work and was hoping for Easter. That seems very early, considering that we are already at the end of March, and we're certainly not going to hit the peak until, by your estimates, at least mid-April and maybe early May. What do you make of the timeline here, and what does the transition look like?
Well, the good news is I think we're going to be good by June or sometime this summer. Now, I know it's easy to say that, but I do think Easter is optimistic. Look, I love the president. I worked closely with him on the price transparency work, which, by the way, is also part of this new bill that's in front of Congress right now. So good stuff is happening. But look, the president's job is to keep people upbeat and optimistic. And I think it is unlikely that we're going to be back to work full steam ahead by Easter. But I've been a big supporter of saying, look, the young, healthy people with no risk factors, let them work and let them do essential services. Right now, we need to keep them back because they are community transmitters, and we don't want that mass influx of rush of patients during the peak to result in rationing. So we want to minimize community transmission. But once we hit the peak, that may be a reasonable time to have our young, healthy workforce out there in the financial services and supply chain and utilities and pharmacy and grocery and healthcare. We've got to keep certain services going just to survive as a country.
Well, Dr. Marty Makary, really appreciate your time and really appreciate your insight. Health policy advisor to Presidents Trump and Obama, editor-in-chief of MedPage Today, and author of the New York Times bestseller, Unaccountable. Go check out all of his work. Dr. Makary, really appreciate your time and your insight, sir.
Thanks for having me on, Ben.
I hope you enjoyed that clip from The Ben Shapiro Show. If you did, go ahead and hit the subscribe button so you stay up to date on all of our future content.